The Emergency Medical Minute is excited to announce that we are now offering AMA, PRA, Category 1 credits via online course modules. To access these and for more information, visit our website at www.emergencymedicalminute.com/CME-courses, or simply click on the link in our show notes and create an account.
Welcome to another episode of On the Streets. I'm your host, Jordan Ourada, as always, and today we have the pleasure of having Dr. Eric Hill, board-certified emergency physician at the Medical Center of Aurora and EMS Medical Director for 9 different agencies here in Colorado, as well as a retired military physician with the Army, former paramedic firefighter, and combat veteran. Thank you so much for being here today.
Happy to be here.
So, today we're going to talk about capnography. A lot of people know a little bit about it, but I think there's a huge gap. So thank you for being here as an expert on this, and let's get started.
Sure.
What would you say is, I guess, the foundational thing that everybody should know about capnography? What is it?
I mean, capnography is really looking at the expired CO2 that we all breathe out. And I think, this has come a long way in the last 20 years. It's definitely become more in the forefront with EMS. Most EMS monitors now, all have the ability to monitor this stuff. When I was a paramedic, we never had this. It was pulse ox or nothing. And we just knew that by the time that they were already becoming hypoxic, that you were way down the curve and that someone could be apneic for, a few minutes sometimes before you would even detect it based on a pulse ox. So capnography, has come a long way in that way because it's really a minute-to-minute assessment of their ventilatory status. And also, I think it has a very important role to play in crews and medical personnel being able to assess the kind of internal physiologic status of what's going on with the patient. I mean, you can tell a lot about their acid-base status and a lot about their internal functioning and what's going on with them. If you can take that tool you're using and apply it to the patient, you can make a lot of good decisions.
Yeah, and I think that's one of the key things to know is that those readings really tell you a lot about what's going on inside. It tells you about what's going on with the respiratory drive and the gas exchange, the metabolism, all these different things. At a very superficial level, people use it to confirm tube placement and say, yes, they're breathing normally. Okay, it's between 35 and 45, and let's go to the hospital, right?
Yeah, correct. And there's definitely been the most basic functions of it is, yes, I can detect, that my tube is in place and I've got good gas exchange. Assuming you have a, normal functioning lungs, it can tell you a lot about the actual physiologic status of your patient, what's going on internally with them, and applying that to the patient, it can really drive your patient care decisions and help you detect underlying disease processes and kind of guide your management. So in that way, I mean, I think the infancy stages of it is really looking at, tube confirmation, but everything from sedation monitoring and sepsis evaluation and DKA evaluation. And I mean, all these things are in play now, and how we use it for cardiac arrest has really kind of, driven how we do cardiac arrest in some cases.
Yeah, I think that's been really fun to see it evolve over the last 15 years. I mean, even just going from colorimetric reading and saying, yeah, okay, we have something, to actually looking at a waveform, understanding what those mean, and being able to look at some of those subtleties in the picture that it gives you, and having that give you real-time feedback about what's going on with your patient, like you said, instead of waiting for a potentially 2-minute delay in oxygen saturation.
Yeah,
so
the old that yellow to purple thing that we always used to have in those old tube confirmation kits. It's the same idea and same concept. That's capnometry, not capnography. And so it's really just, detecting, yes, I'm detecting CO2. And so it's changing basically on litmus paper. It's basically changing the color of the paper. But it can be fooled. It can be fooled pretty easily. If you've got a lot of CO2 in your stomach and things like that, you can really, get significant color change back and forth for many breaths with those devices. Versus, if you're looking at a true waveform, I mean, there's the esophagus does not give you any kind of a waveform that looks like the lungs. So you will be able to detect a bad tube very quickly.
If you know what you're looking for. So let's start at the basics then, I guess. So capnography is a measure of ventilation, not oxygenation, right?
Yeah, it's the best probably measurement of what the ventilation is going on with the patient.
And what you're actually seeing is the exhaled CO2.
Yes, correct. I mean, your body if you go back to just a simple, physiologic level, I mean, your body makes CO2 as part of your normal physiologic processes, and that's what gets into your idea of what's going on physiologically with the person. Because if you have a normal aerobic metabolism, I mean, part of your byproduct, when glucose and oxygen go in the cell, CO2 and water come out of the cell along with ATP. But that CO2 in your body has to go somewhere. I mean, you want to exhale it. And so it is measuring the actual numbers you're getting is actually measuring the carbon dioxide that you're exhaling out of the patient. The end-tidal CO2, the top number, that's really the top number of your peak, but it doesn't really tell you about the waveform itself. So the waveform itself can really tell you a lot about what's going on with the lung functioning, and it can help you detect if there's kind of a bad tube or if there's some other kind of problem going on by looking at what the waveform is doing. It can tell you a lot. But that capnography number is very important. That end-tidal CO2 top number is important, but it really is just a number. And so you have to apply that number to your individual patient.
And so the number is the partial pressure of exhaled CO2, correct?
Yeah, it's a concentration measurement of like how much your CO2 you exhaled. So the end-tidal CO2 would be, I have to remember the exact measurements they're using on it, but it is a measurement of carbon dioxide exhaled during the expiration phase of ventilation.
Okay. And so the normal range of that for a normal, relatively healthy person is between 35 and 45 millimeters of mercury. Is that right?
Yeah, so 40 is the most common number that we would use to say, 40 is normal. 35 is a little low, but it's still within the kind of range. 45 is a little bit high, but within that range. Most people have normal functioning lungs. You breathe at a way that you try to maintain your PCO2 around 40, unless you're trying to compensate for something.
Yeah, if you're trying to blow off excess CO2 from your system,
Yes.
You should see a higher number.
If you're blowing off, if you're really hyperventilating yourself, you'll actually see a low number.
If your respiratory rate is faster.
Yeah, so you're really, because you're basically blowing it all off, and your body is trying to compensate for something on the inside, versus if it's if you're really slow respirations, you may see a high number because you're basically now retaining a lot. You're not actually ventilating it out. It's a very complex kind of counterintuitive system you got going.
And so then the graph should look, each breath has the shape of a plateau, right? And I remember when I was in paramedic school, the person who taught it said, never talk about shark fins, always use the term alveolar plateau. Mm-hmm. And I think that's great, but the shark fin is a useful thing, as we'll talk about later. But when we think about that shape, a normal shape is a pretty even plateau, right?
Yeah, so the way a waveform should look is, it's somewhat almost box-like. And when someone starts the exhalation phase, so they're basically inhaling or holding their breath, and once they start exhaling, that starts your waveform. And that phase 1 is really your inspiratory baseline, and that's just where you're sitting at. Phase 2 is a rapid spike upwards, and that is a very sharp increase. And once that number kind of hits a certain number, there's phase 3, which is really, that's where your plateau you're talking about. And so it's a much more gradual, slower increase. And that's really kind of getting out all that very, minute gas at the very end of your airways. It's kind of coming out. So it's really looking at your alveolar gas at that point. So at that point, there's very little increase in actual true numbers. It might go from a 35 to a 38 during that plateau phase, but it's still kind of, it's exhaling out that during that time. And then that plateau ends. Once you start inhalation, boom, basically the graph stops. It immediately spikes down to 0. That's your inhalation phase.
And so that's normal, healthy breathing.
That's normal, healthy breathing.
And so what are some deviations from that? And what does that mean for us?
Anything that's affecting, I guess, what your gas pattern would look like would be, from a lung function standpoint, if you had, let's say, bronchospasm, if you were an asthmatic or a COPD, you would not see a normal kind of rapid upstroke and a clean plateau, because when you're bronchospastic and when you're bronchoconstricted, you have problems getting air out. And it's not so much a problem getting air in. So you're air trapping. And so when you're looking at that, it looks like almost they call it a shark fin. And so it's a much more kind of blunted rise, looks more like a shark fin in the water. And that's how you know that, you really have bronchospasm or bronchoconstriction going on. That's probably the most common one we see that really affects the morphology. Obviously, if I was to be breathing very rapid, I would see, a much shorter spike, a much shorter plateau phase. If I was breathing very shallow, I might see kind of, the spaces of the respiratory pattern might be more spread out. But over time, if I'm really retaining CO2, I might see that, amplitude of how high my CO2 is rising is really beginning to increase over time. So, usually on your y-axis, you're really looking at, CO2 numbers, how high is my CO2? And on your x-axis is really time.
And so we should be able to see, as we look at any strip, you could look at these with no patient story, kind of like an EKG. You can look at this and say, all right, based on, their respiratory rate is, instead of a normal, 16, it's at 8, and the plateau is at 49 instead of 40. So what does that tell us about a patient?
You can apply it to any patient. I think the key with these things is if you look at when you look at a capnograph, you should be able to say, okay, is it, how high are my numbers? So if the numbers are low, I know that basically, they're blowing off CO2. If the numbers are high, I know they're retaining. You can look at and see, okay, what is their rate? Because let's say this is a minute to minute assessment of respiration. It's not like a pulse ox. So this is really, you can get a very accurate respiratory rate from this. So I can tell their respiratory rate. I can tell how deep they're breathing. I can tell if they're retaining CO2 or they're not, or if they're blowing it off for some reason. I may not know what that reason is at this point, whether it's a normal process or if it's something that's not normal. But you can tell a lot from that. So if you apply that to the patient you have, if I know they're intubated or if I know they have this going on, and if I show them a capnograph, they should be able to tell me clearly, yes, good tube, bad tube, cuff leak. If I tell them this patient is someone with this kind of presentation, and this is your capnograph, they should be able to say, well, this is indicative of, maybe sepsis or some kind of metabolic acidosis based on what I see here, and that can help kind of guide your treatment decisions.
So let's go back a little bit and talk about the use of this in a sedated or intubated patient. What are the kind of the key things that anyone who's using capnography should be aware of when they're using it in that context?
So if you go to, let's just say, sedation. So sedation, capnography, including the hospitals, the capnography is really your gold standard for monitoring. The idea that I can do this just by pulse oximetry alone is not good. Because really, when you're sedating somebody, obviously you're trying to accomplish something, but what we're trying to accomplish is not to knock out their breathing. But any sedative can decrease your respiratory rate. So no matter what sedative you're giving, you want to be able to assess their respirations and have a close monitoring of that. So putting them on capnography is definitely the best way to go for that. And so you can detect, very quickly, are they becoming apneic? Are they slowing down? What does their waveform look like in that way? Whether it's getting shallower respirations. And so I can detect, okay, they're becoming shallower and shallower, and they're becoming less frequent. I can detect that pretty early on. And I can detect it way before they become hypoxic, way before they start having significant changes in their basically body CO2 levels, because I'm looking at really their rate and their depth of breathing. With intubation, it's the same concept. After your initial tube confirmation, when you put it on there, you really want to see a series of breaths that show a good, consistent waveform morphology. And so you put it on there, you have several breaths, and you're really, okay, this looks like a good morphology, and they all look the same. And if I do that for 8-10 breaths and they're looking good, then I'm comfortable that I have a good tube in the trachea. The next part is to make if I start seeing that maybe initially it looks good, but maybe I start seeing that the amplitudes are lower, or I start seeing this kind of weird beveling going on where the amplitude of the sort of the plateau phase of that waveform looks like it's just kind of almost like an AFib. It looks kind of like real rocky. I may have a cuff leak.
Okay.
And so I may have something wrong with the cuff. And so I want to check my balloon, make sure that's up and good, and really just kind of troubleshoot your tube that way. But it can help you detect cuff leaks. It can help if you've got a significant air leak for some other reason, or a tube disconnect, maybe the part of your circuit's broken.
And that leads me to a question. When I was in the field, most of the airways that we have pre-hospital are not ideal, clean, easy airways.
Mm-hmm.
They're often, there's vomit, there's blood, there's problems. And is the pre-hospital equipment we have these days pretty good at working in those environments, or do we have to be really hyper aware of their exposure to liquid or saliva or vomit or any of those things?
I think they're the same, the quality that you would have in a hospital emergency room, but they are certainly sensitive. The way these devices work is they basically are taking a sample of fluid. So it's basically what we call a side sampling device. The actual detector is inside of your cardiac monitor typically. And then you basically have this tube that kind of goes over and attaches to your endotracheal tube, and it's in between your tube and your BVM. And it's basically detecting what is your a sample of air come out. Now, if you've got a lot of blood or fluid coming out of the airway, it can clog your line, and it's hard to overcome. If I have if I've changed that a couple times and I have the tube in place and I mark my depth and I have it secured and I know the tube is good based on my initial confirmation but my line keeps on getting clogged up with fluid, that really can't be overcome unless you can just suction it all for some reason. But if it keeps coming up, you're gonna have a hard time. And so in those cases, I've said, look, unless you have a reason to believe the tube is moved, if you still have good breath sounds bilaterally, the tube depth has not changed, and you really have not, jerked on that tube or anything, I think you're still in good, safe to say, I'm okay that this tube is still good. I confirmed it initially. My device is now bad, but I have good other data to say that my tube is not changed in position.
Yeah, and I think that's a really important thing to be aware of is if this gold standard that we have fails for a technical reason, which is very possible, what are those fallbacks? When we're listening to breath sounds, we visualized it going through the cords, all these things, we marked it, it hasn't moved. Fall back on those traditional things because they are useful, but this is
it is a tool, and it is still the best tool. I mean, the studies they did on the early days of looking at endotracheal intubation with EMS is if they used endotracheal intubation with capnography, they did not have any missed intubations. It showed that they basically were able to detect any esophageal intubation at the time it happened and remove it, so they didn't bring in any bad tubes. You can still fool just the old, calorographic changing yellow-purple devices. You can still change those. Those did have some misses in those studies. So still, the waveform is still your best bet to use. But understanding that if it doesn't work and the monitor's dead or something's going on, you used it, you visualized it. I'm a big fan of video laryngoscopy for that reason because it's recorded. I know it was there. You got good confirmation, good breath sounds bilaterally. You can make sure your tube's the correct depth and you secure it in place. And then you should start seeing a rise in pulse oximetry too, if the tube's good too. So all these things are just tools you use, but you still have to apply it to the patient and adapt to what you have.
Nice. All right. Now I remember when I learned about this, learning about the VQ mismatch, and what the V is ventilations and the Q is perfusion, right?
Correct.
So what is a match? What is a mismatch? And what are we looking for on the capnograph for that?
I think the most important thing to understand with VQ mismatch is that, or VQ match is, this is basically saying you have normal functioning lungs. So if I've got a VQ match, it means my ventilation and perfusion are matched in the lungs. So the air coming in, the lungs, all the alveoli have the proper amount of perfusion going around them, and they create a VQ match. And so what that means is that the air that I'm seeing, I'm measuring external expired air. If I have a VQ match, that number should be really close to exactly what the CO2 level is in my blood. So if I'm doing an arterial blood gas, we get a pH and we get a PCO2, which is the partial pressure of CO2 in the blood, and a PO2. And if I have a VQ match, my end-tidal CO2, which is my measured expired CO2, should match what this PCO2 is. So the reason why that's important is if I'm saying my end-tidal CO2 is 20, which is very low, and I've got a good VQ match, then that should be representative that their PCO2 in their blood is 20, which is very low. So then I have to decide, okay, why is it very low? I mean, why are they blowing all this CO2 off? Is it to compensate for something? Is it sepsis or DKA or whatever that may be? So that's where that is. The important concept of VQ mismatch is that if there's a mismatch for some reason, that could be either because of lung structural problem, and let's just take, for example, if you've got a lung problem like significant bronchospasm down low, or you got pulmonary edema in the lungs, and so you're not getting normal gas exchange. In that situation, I mean, you could see VQ mismatch where you have maybe 10 or so points difference in what you're measuring and versus what's actually in the blood. Likewise, if you had something like a pulmonary embolism, which actually cuts off blood flow to a part of the lung, that can also create a VQ mismatch because you're not perfusing that lung. The lung itself is structurally intact. When you're breathing in, that air is still going down to the alveolus, but there's no capillaries there with blood to actually grab that stuff and pull it out. So the bigger that happens, the bigger the VQ mismatch, the more inaccurate it can be.
And so, what are the most concerning things to be aware of? PE, most of the other things you're going to have a clue based on some history, some medications about your patient, if they have a history of asthma, if they have CHF.
Yeah, I think most times if the lungs sound full of fluid, it's going to be, somewhat not necessarily completely on board. I mean, it might be trending the right way. I mean, if it's low, you could probably believe that it's low inside the body as well. But I think you will add inaccuracy to it. But the trends can still be reliable. I mean, if it starts low and you start treating them and it's improving, that's a good sign. Even if it might not be completely exactly what's going on inside the blood at the time, because we want to treat the patient, not necessarily just the number. But I think pulmonary embolism is a big one. I think anything that could fluid in the lungs, like big pneumonias, maybe COVID-19. That definitely impairs gas exchange. You could have one thing people don't think about too is when you have got like an asthmatic and you open them up, the longer they've been kind of bronchoconstricted, if it's been like days and they've been kind of gradually shutting down, the body doesn't like to give blood to areas of the lung that aren't ventilated. And so if you've kind of shut down parts of your lung because of severe asthma over several days, when you open that up with a bunch of bronchodilators, yes, you open up the lung, but if you ever noticed, what happens with our pulse ox when you do that? It actually drops. That's because all of a sudden I'm basically opened up this kind of dead airspace, and the body's already kind of shunted blood away from that. So you're going to have some irregularities there that take time for the body to kind of reset itself.
To reperfuse and actually use lung
it's going to basically open up those air spaces again, open up the blood spaces back to those areas of the lung and stop shunting the blood.
And how long does that typically take?
I mean, it can be hours before it can kind of, correct itself.
Which we're probably not going to see pre-hospital.
Yeah, pre-hospital. I mean, I just tell people like, listen, if you give someone a albuterol and, their SATs drop, but they look better, and their work of breathing is less, don't be too freaked out by it. I mean, that's just a common thing we see.
Yeah, like you said, treat your patient, not the numbers.
Yeah.
They're all useful tools, but you have to pay attention to your patient always, right?
Correct. Yeah.
And I think another really great thing about this is the sensitivity and how quickly it gives you that feedback. Any comments on that? Anything to be aware of or cautious of as you're looking at those numbers? Like you don't want to be too reactive to them because you're getting that immediate feedback.
I think because it's so quick, you just want to be looking at, applying what you're seeing on a moment-to-moment basis and being able to react to it. I've never been, I guess, afraid of the idea that it's too quick. I think it's just a matter of you're looking at it, but you have to be kind of monitoring what's going on with the patient at the time you're seeing it. If I start seeing all of a sudden a loss of waveform or something, I mean, I know pretty quickly that either my tube is clogged or my line's disconnected or, my BVM popped off or something's wrong or my tube's out of the airway. If I start seeing, quick changes, I want to look at the patient and see, did something change here that I need to address or fix? It depends on what I'm seeing. Certainly loss of waveforms would be a big concern that either the line is clogged or the tube is bad if I'm using it for that device. If I saw no waveform at all on someone that I was monitoring for sedation, it means they're not breathing. So that's obviously,
that's
an immediate,
bad.
Yeah. I mean, so I want to be like really quickly, I'm trying on the spot and identify that quickly. So I think it's actually an incredibly valuable tool when you're using it for those purposes. And the faster it is, in the way the better it is.
Good. Okay. So in addition to using it for sedation and intubation, we also use capnography cannulas. What types of patients would you say those are most useful for?
I mandate its use with my agencies when I'm certainly if we're giving someone some kind of a CNS depressant that's altering their mentation levels. So let's just say I give them fentanyl or morphine or Versed or Valium or something like that. Any of those medications that have a chance to decrease their CNS level, you want to be able to monitor them quickly. So I tell people, I mean, listen, if someone's in agonizing pain and I give them 100 of fentanyl and they, are still like wide awake and talking to me clearly, but maybe in less pain, that's not someone I'm as concerned about. Like I have to monitor the respiratory status because I can kind of tell they're still acting completely normal to me and talking very clearly. But if they're certainly looking like if I gave them fentanyl and they're like, oh, their eyes are kind of looking all dreary and they're looking like they're a little tired now, that's someone I would definitely monitor because I've given them enough that I'm definitely affecting their CNS, and I would want to monitor that. If you're ever giving somebody a sedative with the intent to sedate them, like an agitated patient, something like that, you absolutely want to have it on them as soon as you can. Because that is, how you monitor them to make sure that they are, maintaining their respiratory status despite, having the sedative.
Because they're not able to give you that immediate feedback by talking, looking into your
Yeah,
eyes.
you just don't know what's going on with their ventilatory status at the time or not. So it's the quickest way for us to be able to assess that. So by putting that nasal cannula on there, it's really measuring just the expired gas right at the nose and the mouth. That gives us our kind of most rapid assessment of being able to determine what's going on.
We'll go back to using something for intubation. How is this useful in cardiac arrest? Aside from obviously, knowing what's going on with the ventilations, if you have a good tube, first of all, but then if you're getting some good readings and they're consistent, what can that tell you about your patient and how? I know that you can kind of gauge your CPR related to that. So tell us a
Sure.
little bit about that.
So there's two really, I think, cool things about capnography and cardiac arrest resuscitation. One is actually it can be used as a marker to determine how effective your CPR is. I mean, if you're doing high fidelity, good quality CPR, you should start seeing that end-tidal CO2 number increasing significantly over your 2-minute period of CPR. And so, let's just say they might start off at a 12 or something on their capnography. But when you're doing CPR, if you're over your 2 minutes, I mean, if you can get that number cranked up to 25, 26, high 20s, I mean, you're doing good quality CPR compressions. You've got good ventilation going on. You've got good compressions. Because, I mean, what that's really measuring, right, is, remember what I said before about what CO2 is? CO2 is a measurement of cellular respiration. It's about, it's being produced by your cells that are getting oxygen to them with glucose and making CO2. So there's really nothing else making that inside. So if you're actually able to, do CPR and get that CO2 numbers up, that's a good sign. That tells me that that's a, potentially viable patient. It also tells me that, you're doing good quality CPR compressions. So it's a good prognostic value for us. The other thing it really tells us is if I'm doing CPR and, I have this tube and I'm doing consistently, let's just say it's consistently during the CPR phases, I'm in the like 22 to 25 range. And all of a sudden I get this, spike up to 45, 50, 60 on my CO2. That is a very good sign that I now have ROSC. I now have a returned pulse. And the reason is that, as good as CPR is, and don't get me wrong, CPR is not that good. I mean, even the best compressions we do, it is nowhere close to being able to have the same kind of cardiac output of what an actual normal intrinsically functioning heart is doing. So if I'm, a normal functioning heart, let's just say their ejection fraction is, 60%. A small fraction of that is what I can generate by external chest compressions. It's hopefully just enough to kind of keep their body alive and their brain alive. It's very rarely enough to actually get them to like wake up or anything like that. And so, if I have a big increase all of a sudden, that tells me that, boom, underneath that, their heart has actually started and blood is now circulating around again, and it's gathering, blood from the external tissues and bringing it back up again. So that's a sign of ROSC. It can be fooled, and there are a few things that can fool it. Namely, if you were to, let's say, give somebody a big dose of sodium bicarbonate, if you think this is a hyperkalemic arrest and you're going to give bicarb, if you give a big dose of bicarb, the way the acid-base buffer system works in the body, when you give them bicarb, it binds to the acid and it breaks down to two compounds. It breaks down to water and CO2. So giving somebody a bunch of bicarb will all of a sudden give you a spike in your end-tidal CO2. Doesn't mean you have ROSC. It just means it's just a it's a normal physiologic process based on what you gave.
So, all right. So that brings two questions to my mind. One is, in a lot of these patients who go into cardiac arrest, when they come out, they don't have the best ejection fraction. So if someone, has an EF of 15 or 20 and their heart kicks in, are you still going to see that big bump? Still more effective than CPR at that point?
Almost always, yes. I mean, in my experience, every time I've had a cardiac arrest patient, if I have them on capnography and I get ROSC, I do see a spike. And the way I usually would know that is I see the spike and I either immediately, check for pulses. Some monitors can actually kind of give you an underlying kind of cardiac rhythm. And so you could kind of detect, okay, do I have an underlying perfusing rhythm and do I have this big spike? So do I have ROSC? Or I can even do like an ultrasound on their heart and seeing if I've got a normal squeeze look like going on in there. So there's different things you can do, but I think it is a good sign when you see that. You should still see a significant spike, and the degree of the spike is always different. But if I'm going from 20 to 40, I mean that's nothing really does that, and typically the spikes are even a little bit higher than that.
Okay, interesting. And then the other thing is, I guess we should back up a little bit, as you mentioned sodium bicarb and how that can affect the intercellular activity. Give us a brief overview. I know there's a ton involved in that, and most people don't remember all of the ins and outs in the Krebs cycle and stuff from their A&P and Bio 1, but give us the nitty-gritty important stuff about that.
So this gets into your acid-base class, and so this is hopefully make it interesting without making everybody's eyes glaze over. But acid-base physiology is pretty key to this whole component and what we're doing in the body and why it works. The newest stuff we're using in capnography for is really like sepsis identification, and this is really where this comes into play. So in a normal body, as I said before, your body makes CO2 and it exhales it out. And when your body likes to maintain a certain pH, it does not like any variations in it. And we all like to live around 7.4. And so the body will do all kinds of things to maintain that pH, whether it's, it can retain more bicarb through your kidneys. It can make you breathe faster. It can do different things to try to accommodate that, but it wants to maintain that. So if I say normally, I live at a pH, I've got no lung disease. I live at a pH of 7.4 and my PCO2 is around 40. That would be normal for me. But if I'm like a COPD patient who's a chronic retainer, their their pH is also probably 7.4 because that's where the body likes to be. Now their PCO2, because they're a chronic retainer, might be like 55. And so that should affect it. But what happens to the body is over time, it actually retains bicarb to compensate for that. And so even though their PCO2 is higher, they have higher bicarb levels in their body to try to basically compensate for that process. And so I can tell if they're an acute failure from COPD by kind of looking at their blood gas and measuring those kind of things. But that's the general idea behind it. The reason why this is important with the acid base, like I said with CO2, is acid is basically hydrogen ions. It's the H plus. And bicarb is, it's just that sodium bicarbonate, but it's really the bicarbonate that we're looking for in this. The bicarbonate is, HCO3 and it's negative. It's negatively charged ion. When those two come together, okay, so you get H2CO3, and that lives in equilibrium with water and CO2. And so when this hydrogen ion binds the bicarbonate, it basically gets dissolved and it breaks down into a compound of water and carbon dioxide. And one of the ways the body can compensate for acid problems is if I'm becoming acidotic, it's going to want to shift that curve over to the right side. So I'm going to blow off tons of CO2 to try to compensate for that. Because if I have a CO2 buildup, it can't do it, right? It's the hydrogen ions are binding to the bicarb, but then they just kind of they fall apart again because they're backing up in the system. So it lives in an equilibrium. So one of the ways the body detects, if you're acidotic, is it blows off your CO2. And it's going to increase your respiratory rate and increase your respiratory drive to try to blow it off so that you're compensating for an acid problem.
So if you see someone breathing fast, heavy, deep, you can assume that they're acidotic.
Well, it's a possibility. You don't know that, right? Because let's just say if you're a panic attack, they look like they're breathing, rapid, deep, and everything else. But if I actually, was to put them on capnography, they are blowing off CO2 inappropriately. I should see a low CO2 number, but I'm looking at their lungs that are clear. I'm looking at their pulse ox, they're 100%, and then I'm like, okay, well, what's going on? I mean, is this really an acid problem? Or is this just a more of a psychiatric problem that's kind of causing this? But yes, you're correct that if a metabolic acidosis develops, DKA, what's the classic term we always use for breathing in DKA patients? Kussmaul, right? Kussmaul breathing. Kussmaul breathing is rapid and deep. And that's what the reason why that is because of the acid. The body is in DKA. DKA is diabetic ketoacidosis, and it is an acidotic state in the body. So your pH of your body is low. I mean, I've seen them as low as like 6.7, 6.8, incredibly low, I mean, near death. And they breathe very deeply, and they're breathing very rapidly because they're trying to blow all that CO2 off to try to compensate. They're trying to basically save their life. Their brain is kicking everything in overdrive, doing everything it can to try to rectify this acid base problem. And so it's going to breathe very rapidly, very deep. So I look at that when I see people that are breathing that really quickly. First thing I want to know is, okay, I want to know what their blood sugar is. I want to know what their, I want a quick blood gas on them, or or even just like a lactate, to really kind of say, okay, is this kind of sepsis? Is this a diabetic problem? Because sometimes I've detected people that say this is, they're having an asthma attack, and I'm like, well, they have a history of asthma, but they're not wheezing, and you can put them on capnography, and they're not bronchoconstricted, all right? So, once again, if you think this is something, they're breathing really fast because of asthma, if I put them on that capnography and they don't have bronchospasm, they have a normal waveform, and it's not a shark fin, you can't say their shortness of breath is due to asthma. I mean, you need to really look back and say, okay, is there something else going on? Are they just breathing fast because it's a panic attack, or are they breathing fast because they're compensating for some other internal process?
And I think that's an easy one to get fooled on for a lot of people too, because DKA is often the first presentation of someone with diabetes, right?
Mm-hmm.
If new onset, if they don't have a history of diabetes, they're breathing this way, that maybe isn't going to be the first thing that pops into a provider's head. And so understanding what those numbers mean, and is this a solution to a problem, or is it a problem that's being created by some other problem like anxiety, right?
There was actually a study in 2015 that looked at using capnography in diabetic patients with hyperglycemia, and what it said was that if these patients that had I think the sugar was over 550, so if they had a sugar over 550 and they had a entitled CO2 level less than 21, 100% of those patients had DKA. So basically what that's saying is, okay, yes, they're hyperglycemic and they are metabolic acidosis, because once again, if you're acidotic, your body's going to breathe fast to try to compensate. So what you will see on capnography is you'll see a low number. You want to see a low CO2, and that's indicative of that. So if you had let's say hyperglycemia, but your entitled CO2 was normal. I mean, the study said if it was over 35, then 100% of those patients did not have DKA. None of them did. So it can kind of give you an idea of, okay, I mean, they're vomiting, they have hyperglycemia, check their blood sugar, it reads high. I could put them on a capnography real quick, and if I see a really low number, I mean, I can be pretty certain that this is probably a DKA patient. That might change where you take the patient, depending on what it is. I mean, if you're trying to decide between like a freestanding emergency room with less resources who really can't admit a DKA patient, they'll have to transfer them again anyway. Or if you're saying this is a place that actually has an ICU, then you might take them over to the ICU. That'd be a more smart decision, because you've already said, I think this is DKA based on this. In the end, our management right now in the EMS is, okay, I think I've identified a problem here. I'm going to start giving them volume, right? I'm going to give them fluids.
Yeah, try to
Just
flush
really what
them
they
out a
need.
little bit.
Yeah,
And really, that's all we can do. We don't have insulin in the field.
correct.
So.
Well, the number one, even if you did have insulin in the field, the number one thing they need immediately is fluid, because they're incredibly volume depleted. So they need IV fluids. I mean, DKA patients typically, I've seen 5-6 liters volume down for what they need. If they're actually like a hyperglycemic, non-ketotic coma type patient,
Yeah.
I mean, their sugars are like 1,200, 1,300, 1,500. And those patients are more like 10 liters depleted. So they need a lot of fluid to kind of compensate. So in your time with EMS, giving them a liter, even 2 liters if you have a long transport is not inappropriate, because they are weighed down in what their volume status is. And that's the first thing we do in the ER. I'm going to give them volume. And then once I know what their potassium is and stuff, then I will start giving them the insulin, because initially I need to give them the volume.
Okay. So we know kind of how it works with cardiac arrest. We know what it can do for a DKA patient. How about some of those? We talked a little bit about asthma and seeing that shark fin and having that, people who are retaining
Mm-hmm.
CO2. What is it going to look like for a typical COPD patient or a CHF patient?
So, particularly with your bronchospasm patients, which is your asthma and COPD, they'll look very similar. The difference is your endpoints might be different. So remember, an asthmatic, their baseline lung function should be normal, and so you might see a shark fin and some CO2 retention. Initially, you actually might see their CO2 might be down a little bit, right? Because if they're kind of feeling like they're anxious and panicked because they're giving a hard time breathing, they might, before they even start retaining, they might start increasing the respiratory rate because they feel like they're oxygen starving. So their PCO2 might be initially a little bit low, but you will start seeing shark fin. Versus the COPD patient, the morphology might look the same, but their endpoints are different, right? Because they might be starting more like at a 50. And so I won't just make a clear statement of, hey, this is acute COPD based on just the number. I really have to look at what the waveform is doing. I'm looking for that shark fin pathology. If I'm doing the right thing and they're getting better, okay, their shark fin should actually start kind of normalizing, right? So if I'm improving the bronchospasm, then as I exhale out and as I improve things, it will actually cause that waveform to actually becoming more normal as they improve. CHF is you won't necessarily see a bronchospasm type waveform on it. What you may see more is that if it's causing CO2 retention for some reason, I guess the numbers could be higher. Once again, with CHF, because of the pulmonary edema, it may not be a completely, you have some degree of maybe a VQ mismatch there. You may not have complete gas exchange depending on how full of fluid they are. So the morphology might look very similar to what you're normally seeing, but if they're breathing fast, obviously um, it'll be respiratory rate will increase on it, and you may start seeing shallower respirations because they're full of fluid. They really can't oxygenate enough, so the amplitudes you're looking for might be more compressed. They're not breathing as deep.
So if part of their lung space is covered with fluid, you're not getting good gas exchange through that fluid. So basically, the lung volume that's useful is much smaller.
Correct. I mean, they don't have the parts of the lung that are oxygenated and are functional are not as good. So they'll have pleural effusions in the bases, and that compresses part of the lung, and they get pulmonary edema in the alveoli, and those ones that have significant pulmonary edema just don't oxygenate as well, which is why they respond so well to BiPAP and stuff.
And typically, those patients, when you think about it physiologically, if you have some fluid in the lungs and you are laying them down, you're covering more of the lung tissue with fluid. Whereas if you sit them up, it settles down to the bottoms and covers less. And that is why they do better and why you'll see better numbers if you keep those patients sitting up. And usually they're going to fight with you, right?
Yeah, I mean the most advantageous way to breathe is sitting upright and actually leaning forward. It's kind of like your tripod position.
Mm-hmm.
That's what we see. So if you think about it, I mean, if I'm leaning forward and I'm, in the optimum position, my lungs are kind of hanging off the back there, and so they're going to be the most maximally inflated they can be, which is why classically tripoding patients are leaning forward and they're sitting bolt upright. They don't want to do anything else. Laying flat is a disadvantageous problem because now you have the weight of your chest wall on top of your lungs and also your diaphragm. I mean, one of the ways your lungs inflate is your diaphragm. If you're laying flat, it's not dropping nearly as much. Versus if you're sitting upright, you got gravity helping to pull that diaphragm down, and it's making the abdominal contents go down more, so you actually can have better respirations. So laying flat is not advantageous for breathing at all.
And so typically when we're working in cardiac arrest, that patient has to lay down because we're doing compressions.
Yeah.
Can you identify a patient who is a severe CHF patient through capnography in a cardiac arrest patient? Does that make sense?
I've never used it that way. I think I would have much better physical findings to suggest this was a CHF.
Yeah, you'd see edema.
Yeah, I mean, pitting edema. They might have significant JVD. The history they have. I might listen to pulmonary edema. So, and it wouldn't probably help guide me too much in the way I would treat that patient at that time. Once you're in CHF and cardiac arrest, I mean, the management is basically no different than any other kind of cardiac arrest. There's nothing much more I can do at that particular moment. We've already hit the point where their heart is stopped. We had our opportunity to intervene with BiPAP and and vasodilators and things like that are already kind of gone. So we just got to get the heart restarted and best we can, and then put them on some positive pressure ventilation. But positive pressure ventilation in CHF works incredibly well.
All right, and so you mentioned before the Kussmaul respiration. That makes me think about some of our head injured patients and how someone with a significant head injury can see a change in their respiratory pattern. How can we use capnography in those types of patients?
I think the best use of it is for a really close monitoring of what we're doing. There's two things, the worst things that we know for head injury. The two worst things are hypotension and hypoxia, because no matter what happens with their head injury, if they have hypotension or hypoxia, they definitely have an increased risk of permanent brain injury associated with it. So we want to avoid those at all costs, which is why we don't practice permissive hypotension with trauma patients who have head injuries. It's why we want to make sure we fix any hypoxia statuses as fast as possible. And when you're looking at, because this is a good measurement of avoiding hypertension hypoxia, we'd also, we don't hyperventilate them unless absolutely we have to. It used to be, I remember, when I was a paramedic 20 years ago, it was, okay, yeah, if you think you got a head injury, you hyperventilate them. And we know now that's actually not necessarily a good thing. It's actually a bad thing in many cases. When you hyperventilate somebody, you're actually causing vasoconstriction. And so you can decrease blood flow to part of the brain, can cause secondary injury to the brain tissue. So we don't like to hyperventilate patients. The only time that the clinical guidelines really recommend hyperventilation in the acute setting of a head injury is if there's signs of active herniation. So if I have a patient who's obviously got a significant head injury and I start seeing decordicate posturing, I start seeing decerved posturing, I start seeing, one of my pupils ipsilaterally gets blown, and I'm having some contractures. I mean, all those things are bad signs neurologically. They are herniating. That's someone I would consider hyperventilating that patient and actually blowing off CO2. So if I have them intubated, I mean, normally we try to say, 10 to 12. I'd easily hyperventilate them 20 times a minute. And it's a short-term fix, and I know that I'm potentially causing a problem on the back end. But really, I mean, if they herniate their brain, there's really no recovering from that.
There's no coming back from that.
There's no coming back. So, in that way, CO2 could be helpful to measure, because you don't want to hyperventilate them so low that it's a problem. Typically, we say we hyperventilate them down to like 35 would be your number. So if you were say, okay, I'm going to, I have them on capnography and they're now showing signs of herniation, I might hyperventilate until I get to that point where their end-tidal CO2 is like a 35. And then I can say, okay, I'm going to kind of maintain that, because I know I don't want to go too far, but I know I can and monitor it closely that way.
And so the goal there is to try to actually cause some vasoconstriction and reduce swelling.
Yeah,
How
the goal
is that?
It's a short-term fix. It's not a long-term fix. It is mildly effective. It does cause some decreased intracranial pressure when we do this. On the back end, I can have some underlying injury that occurs because of that. So it's really a stopgap measure. We really only use it for the most extreme cases. And really, if I want to see herniation, if I don't see herniation, I just want to keep them neutral. I mean, I want to keep their blood pressure good. I want to keep their MAP blood pressure, their mean systolic pressure, high. And I want to keep their oxygen levels at near 100%. And that's the best I can do to maintain that and make sure that they're getting good blood flow to the brain that way.
And so in a pre-hospital setting, would you recommend that providers be aware of that and think about that and act on that? Or would you suggest that's a call and talk to a doc, say, hey, this is what I'm seeing. I'm thinking about, I want to, hyperventilate them a little bit because of this. Do you agree with that? Do you think that is required, or is it like...
It depends. I mean, the physiology is sound. I mean, these are in the clinical practice guidelines through the military, and they're all over the place. This is how you kind of manage these things. I think the one thing is, first is you would factor, okay, what do my protocols say I need to do with this? Do they even have this in my protocol? I mean, if they don't have anything there about hyperventilating a head injury patient, you should talk to your medical director and discuss, like, when would this be appropriate, or could it be a standing order or a direct order?
Yeah.
Next part is
don't go rogue because you heard this podcast.
Yeah,
right?
I mean, so it's you don't want to do that. I think that the medicine is sound behind it. There's no disagreement that hyperventilating head trauma in general is bad. That is not that is pretty well established. But I think you want to make sure that you're following the directions you have. I think, though, you would factor is how far out am I? from where I need to go. And there's other things I can do to lower increased, ICP besides just hyperventilating that we didn't even talk about, like you loosening the C collar, raising the head of the bed, raising the head of bed up to 45 degrees or 30 degrees, and decreasing the C collar on the neck. I mean, all those things will actually have significant decreases in your ICP. Hyperventilation is an option. It's a short-term gap. I only use it for hyperventilation. If I have a long transport still, if I still have 15 minutes with this person and they're already showing signs of herniation, I think it's a very reasonable thing to do. I think the downside is much less than the potential risks involved. But something that definitely to make sure see how your director feels about it.
Yeah. I'd say that across the board, right? When in doubt,
in general,
call.
yes. Just because you heard it from me, don't necessarily fall back on that.
Any other interesting things with head injury that we can glean from looking at their capnography or patterns we might see in respiratory patterns?
Different head injuries can cause different kind of physiologic phenomena. So you'll see, Cushing's triad. You can see Cheyne-Stokes respirations. So all those will be there. I mean, Cushing's triad, they'll start seeing hyperventilation. They get this kind of irregular type patterns going on, and so they usually will be hypertensive, bradycardic, and have irregular respiratory patterns. So you might see some kind of really abnormal respiratory patterns on your capnography. And if you're looking at it, I mean, it'd be the same way if I'm looking at it, I'm like, wow, it doesn't look any kind of regular. It's almost like an AFib of capnography. It's not regular. It's not consistent. It's just kind of like, doing different things. And I can look at the patient and say, yeah, you're definitely showing that. And I'll see other signs that are showing signs of increased ICP, such as the hypertension, the pupillary reflex, and the bradycardia, which is all part of that Cushing's triad.
And on its own, not going to change your care or treatment, but a good clue.
Correct. It's something you just
direction.
monitor, but it would not necessarily change what I was doing with that patient at that time.
Okay. We talked a little bit before about sepsis, and I think that is probably one of the biggest changes over the last, I don't know, maybe 5 years that I've noticed is how we're using this as a really valuable and accurate tool in identifying a septic patient and what's going on. And it makes sense when we think about how important this is and what really an illustration of the intercellular metabolism and what is cellular respiration. Is that what the term we use?
Yeah, cellular respiration is a good term. I think the key with sepsis, and where I would start with this, is saying that, I mean, it is one of the biggest health care dollar expenses in the country. I mean, billions and billions of dollars every year on sepsis management treatment. It also has an incredibly high mortality, so much so that, I mean, there are literally national guidelines that, emergency rooms follow, which really tell us that, there's a time window, like from the time they hit the doors, we want all these interventions done, all within that first hour. I mean, they want blood cultures, they want, all the vital signs, they want 30 cc's per kilogram of IV fluids infused, they want, broad spectrum antibiotics given, they want lactate measurements done, they want all this from the first hour. And that's a tall task, especially, if you have let's say a backed up waiting room, or, you've got a busy ER. So you want to really have a process in place to do this quickly. And that's why they do this, is say, we really want to do the best care, because they've shown, I mean, the data does show that if you give them these fluids, you give them these antibiotics, and they have septic shock, I mean, you absolutely can decrease mortality. I mean, significantly decrease mortality, decrease hospital stays, decrease dollars, and decrease mortality. So that is why we do it. It's a hot topic in emergency medicine, and it has been for several years, and will continue to be so for a long time. The reason why it's important with EMS is, there are things that we can do in EMS to help identify this and actually initiate treatment and give them the right things quickly. One of the things we do in emergency rooms is we measure lactate. And as we've talked about before, I mean, normal aerobic metabolism, there's no lactate generated. It's basically, your glucose and your oxygen goes in, your CO2 water comes out, you get ATP, and that requires that you have normal oxygen, normal cellular function. When you have lactic acid, when you have an anaerobic metabolism, you basically have exceeded your aerobic metabolism, and you get lactic acidosis. So lactate is a byproduct of the energy generated from this anaerobic metabolism. So, if you're a runner and you do this big marathon, you get that burn in your muscles, everything, that's all lactic acid buildup. I would hate to think of, what the pH of these, marathon, ultra marathon runners when they come out. I mean, it's got to be incredibly low. You look like they'd be dead probably, but they have very good clearance mechanisms to get rid of it. So lactic is what we measure. And the two numbers we really care about, I mean, normal is like 0 to 1. I mean, really, anything over 2, we consider it to be severe sepsis. Between like that 2 to 4 range is considered severe sepsis. And if it's over 4, it's considered to be septic shock. And so, most ambulances and fire trucks, they don't carry lactate monitors.
And what we found is in the last decade or so, agencies have tried to use them, and they're not very reliable, right?
Yeah, well, the problem is they like to have kind of a nice, kind of cozy environment to live in. They don't like to be bumped around. The cartridges like to be kept at a certain temperature. I mean, so there's complications with trying to do them. We do them point of care in emergency departments, so it is a point of care test you can do. But I think that there's troublesome issues around trying to use it with an EMS. Not that they can't be overcome, but it is troublesome. So most times they don't have this, and even if they did, it's a cost. It's a significant cost to be able to run a lactate program out of an EMS agency. But one thing we all have, if you're an ALS department, you've got capnography, and we just had this whole big talk about what is how acid base works. So if I've got lactic acidosis, my body is going to increase my respiratory rate, and it's going to blow off my CO2 to try to compensate. And that's how that's going to kind of work in that acid-base buffering process. So we know that if you have lactic acidosis, you're going to be blowing off CO2. You're going to have an increased respiratory rate and blowing off CO2. That's normal physiology. Dr. Hunter did a study in 2016, and they really looked at, can we use end-tidal CO2 as a surrogate for lactate? And the answer is yes. It kind of looked at these different numbers, and it measured different things. And what it kind of found was that if you have an end-tidal CO2 of less than 25, that correlates with a lactate of 4 or greater. So if I'm thinking, okay, I've got, possible sepsis, and I've got this patient, they're fevering, they're tachycardic, and I put them on capnography, and their CO2 is 20, that is a good correlator that their lactate is over 4. And so that would be enough to say, yes, this looks to be sepsis, and I should initiate treatment at this time. That treatment may be anything from, fluid boluses, notification to the ER. Some systems I've seen around the country actually have broad spectrum antibiotics on the ambulances, and they just have orders to go ahead and start giving them like Rocephin or things like that right in the ambulance. I think that's very much a system dependent issue. Like, how far of transport do you have? And it's not a benign intervention. That's a pretty serious intervention. But if you've got like long transport times and kind of curvy hills, and you have problems getting to good access to care, that may be something that the medical director implements in that system to say, yes, we can do this. When I was in Iraq, I had a couple of rural remote aid stations that, we really didn't have a doc or a PA to put out there. But we had like a senior medic with like a group of like 25 people, and we gave them kind of broad, abilities through extra training and kind of medical oversight to where, hey, if you have these kind of things, call us on the phone. We'll talk you through it. But starting antibiotics on things that would normally be in their scope, but we'd say, yes, you could do this, and you could, you can call it, and maybe the next morning they'd be on the medevac pickup to come over to us and let a doc see them, but just was not delay care. There's unfortunately a very big issue if you're trying to call in an urgent medevac. I mean, that's a big dollar expense. That's a big risk to the crews. So if it seemed more minor and they just need, an infection that needed antibiotics, but they were otherwise stable, we had the medics basically call in a report. We talked to them and said, yeah, you have a cache antibiotics there. Go ahead and give them this, and then send them over here tomorrow on the routine, convoy that's coming over here. We'll take care of it.
And that'll buy you some time.
It buys us time. We want to start things early.
Yeah,
so that's where we do those things. We started doing, in my EMS agencies and a lot of EMS agencies, we started doing these sepsis alerts. And the idea behind it is that if I have 2 or more SIRS criteria, and your SIRS criteria are really just physiologic criteria that we're using: heart rate, respiratory rate, temperature, and white blood cell count. Now, I can't get a white blood cell count on an ambulance, but I can get, the 3 other SIRS criterias. And really, sepsis by definition is really, I have 2 SIRS criteria present, and I have a suspected infection. That's all it takes. So if I'm tachycardic and febrile, and I'm coughing, and I seem like I've got, some kind of upper respiratory infection, I've got sepsis. So if I've got 2 SIRS criteria, and at this point we say, okay, if you've got 2 SIRS criteria present and you think you've got infection based on what you're seeing, then go ahead and put them on capnography. And if I got a capnography now of less than 25, or if their blood pressure is less than 90 systolic, that's enough to say they've got septic shock. And I'm going to go ahead and call sepsis alert, let the hospital know to be able to receive that. And I'll start the IV fluids, because all the IV fluids that the EMS give, I mean, if they can give 500 cc's or 800 cc's of fluid before they even get to me, that all counts in the IV fluids that the patient needs as part of those quality metrics. Like I told you, it was 30 cc's per kilogram. So if I have a 100 kilogram person, that means in that first hour, they need to have 3 liters of fluid infused, and the antibiotics and the blood cultures and the lactate and all these things done. If I can get a portion of that in there ahead of time, that's incredibly helpful, and it's a good thing. So it shortens the duration for us to be able to complete the bundle, to be able to complete the care that they need. And it also gets that doc in the room quicker, because we all know that if there's a really busy day, and, although the docs try to meet every single ambulance, it doesn't always happen. If I'm backed up and, if I've got, 3 level 2 chest pains waiting to see me, I won't always necessarily go right to the ambulance if they look okay, unless the crew identifies this as someone that needs to have a doc on arrival. So if I have a crew tell me, hey, I've got a sepsis patient, this is what I got, they're, even if their blood pressure's okay, but they're tachycardic, they're febrile, they've got low entitled CO2, they've got an indwelling Foley catheter, they're altered, or whatever that is, that's enough to say, sepsis alert, get the doc in the room, the doc can evaluate them quickly, and then initiate the bundle, order the antibiotics, order all that stuff, and it greatly decreases the amount of time that it would normally take for them to get all those things completed. And once again, time is tissue. It really is just like a heart attack and a stroke. I mean, we really think that the sooner we can do this, the better it is for the patient, decreases mortality.
And what other mechanisms does that spin up in an ER? When we hear those numbers, when we hear this is a sepsis alert, and we know we can trust that because the EMS agency has given us this concrete information. Mm-hmm. Aside from getting a doc in the room and starting that, are we contacting the pharmacy? What kind of other stuff happen when we know we?
So it depends on each hospital. Might have a little bit different process to how they internally do it. We treat it like an emergent, essentially. So basically, it means I have a nurse, a tech, and a doc in the room upon arrival. In my ER, we actually have a clinical pharmacist in the ER at almost all times. And so the pharmacists themselves will take it upon them to go ahead and grab the antibiotics. Pretty commonly, there's usually 2 or 3 go-to antibiotics that we give for most, frontline sepsis patients, like Rocephin or ceftriaxone. That's a very common one for initial management. So initiate that therapy. So, I mean, if I'm right there in the room and I say, yep, let's go ahead and do the bundle, the pharmacist is right there, I can say, yep, go ahead and grab the antibiotics, and there's no more delay in doing that, because the pharmacist will go grab it and bring it right back to the room and hand it to the nurse, and it's hung. So, I mean, it can be hung within 10 minutes and, shortens all that duration of time, versus if I have to, order it, and the pharmacist has to acknowledge the order and send it over to the pharmacy, and that just delays time. So we really try to put processes in place in the hospitals to shorten the amount of time that we can complete all the things we need to improve mortality. And we're, most hospitals are really good at it. Like, we're really good at it at my hospital, but it's an ever-going, challenge process we do, and it's something you have to train on. But
yeah, and that's been a really interesting thing to see over the last just couple of years. I've noticed is now we're tracking our door to antibiotic time, just like we've always tracked our door to needle and our door to balloon. And we know that these metrics count towards survivability and people walking out of the hospital, which is great. And so I think EMS is probably going to start hearing and getting notes from the hospital saying, hey, way to go. On this sepsis alert, we had a door to antibiotic of 7 minutes, and this patient went home in 3 days. Whereas if it had been extended to a half hour, 2 hours, that would be a very different outcome.
It is an incredibly valuable tool. And what we found is that when EMS does call it, I mean, we definitely have a decreased time. If I was to take all comers of patients, those who just come in by normal triage, they walk in and then they get triaged, and the time it takes me to do all the bundle compliance for those patients versus those who come by EMS, the EMS is definitely shorter. And it's shorter, especially if they pre-identify it as a sepsis patient, because then there's no delay in getting the doc over there. And the doc's already kind of keyed in that we need to be going this route quickly, and they'll look at it. But they've been very accurate. I mean, they've been very accurate. And, the ones that they say this is a pre-hospital sepsis alert, that's a very accurate for the most part, of saying that, a lot of times those are sepsis patients and they were correct. And in the end, I mean, the whole goal of this is to save lives, and that's all we do. So if we think, if we think this is saving lives and we've got great mortality numbers, then we should keep on trying to improve that process.
And you had mentioned that study that said below 25. What is the sensitivity, specificity of that? If we're seeing those other SIRS criteria, you see two other things, and you're below 25, is that like 100%?
No, so it's not 100%. So it was so in the study in 2016, they did a very similar trial to what I said that we use here with my systems. Is they used the two SIRS criteria and then those kind of two markers, either the end-tidal CO2 or the hypotension. And what they found though is that with the hypotension, with the end-tidal CO2 less than 25, if they have two SIRS criteria, it was 90% sensitive and 58% specific. So what does that mean is, 90% sensitive means that 90% of the time they captured everybody that had that criteria. It wasn't particularly specific because I'm saying there's other things that can cause you to be tachypnic. I mean, you could be tachypnic and blow off your CO2 because you're febrile or because you're panicked or something like that. So it's not terribly specific, but in a screening tool, the most important number is sensitivity. You want to make sure that you're not missing things. So if it's not sensitive, it's not a good screening tool at all. And when you look at negative predictive value, which is basically saying that if I don't have all these things present, then I can exclude it. It was 93% negative predictive value, which is pretty good. So I've been saying that, if they didn't have an end-tidal less than 25, I can exclude that 93% of the time that this was not a septic patient. And so that's a good number to know too, is, when you're looking at all these, data and stats. And I am not a data and stats guy. I did that in college and it was a rough course, but the numbers needed to treat, the negative predictive value, positive predictive value, and sensitivity, specificity are all pretty important for clinicians to know.
So it sounds like this is a really valuable tool for septic patients and this new wave that we're seeing about how significantly sick these patients can be and what a burden they can be on the healthcare system.
I think it's an incredibly valuable tool. I think, if you have capnography and you have the ability to do nasal capnography on your ambulances, I mean, you should have a protocol like this. You should have a sepsis protocol, a screening protocol. I mean, it is absolutely the right way to go with everything that we're doing with these things called the Surviving Sepsis campaign across the country. It is an early recognition tool, and it is a valuable guide tool to be able to identify patients early. The earlier I can identify them, the better off they are. And once again, if I know, based on what if I can screen them and say, yeah, I think this is sepsis, I get them to the right hospital, I get them to the right doctor, I get the place that has the right resuscitation capabilities. I mean, all that's good for the patient, and in the end, that's what we're all doing this for every day.
Well, this has been a really dense podcast. We've gone over a ton. Are there any things we haven't talked about yet that you think we really want to include?
Oh man, I would say that one thing when you're looking at capnography is just get comfortable with what these waveforms look like and what normal looks like and what's not normal. And so, it's not infallible. Okay. It is a tool and you need to know kind of the limitations of it. And I discussed a lot of them here, but you can tell a lot about what's going on. And if you apply it to the individual situation you're in, if I'm looking for sepsis or I'm like, what's going on with this? I got these weird numbers. I can apply that to what I'm looking at and apply that to the patient. I mean, I can use it to screen for a lot of things. I think by far and away, the number one things that EMS needs to use this for is sedation, monitoring. It's a gold standard in the hospital. It's mandatory. It should be mandatory in EMS. Tube confirmation, without a doubt, is by far the best tool we have to be accurate. And then probably 3 is sepsis would be the number one things I would focus on. Those are your biggest ticket items, and I think they're the kind of the most cutting edge areas and also the more traditional areas, but they're most high risk areas for EMS, and I think those are probably the areas we should really focus on the most.
Perfect. And for anyone who wants to dig deeper and figure out more about how to use this tool after they get comfortable with what normal is and how we can use it in those specific cases, any literature you'd recommend? Any books?
Actually, if the manufacturer, I think for the capnography, a lot of them are like Massimo, and so if you look at those manufacturer websites, they actually have good training videos, really on capnography, what it is, how to use it. There are if you go to like even like a YouTube channel and you find, a lecturer that's, a physician that's kind of giving some of them are like medical channels. They really kind of give pretty good rundowns of kind of how this is applied. I think it's a complex topic, and I think it's the hardest part is without really seeing it and having this kind of hands-on look at it and looking at it while you're talking about it. It's hard to understand because a lot of things are inverse. And like you were saying before, a lot of people think, okay, if I'm septic, it's gonna be high. No, it's actually low, and this is why, because it's an inverse relationship. And so a lot of things are complex topics. And trust me, I learned about this stuff not because I'm the best studier in the world. I'm not. I was a procrastinator, through college, but I found that by learning it and by teaching it. I became way more comfortable with it and actually became a really good educator about it as far as how to use this. And I think it's really the gold standard of where we need to be using to assess ventilatory status and kind of physiologic status of our patients.
Outstanding. Thank you so much for your time, Dr. Hill. I really appreciate the conversation today. My mind is super full right now. I'm sure our listeners are, so going to take a little time to decompress that, but a lot of great information. Thank you so much.
Sure, anytime.
We are on a quest to provide the world with free medical education. Please help us out by rating us on iTunes, following us on social media, and subscribing to our newsletter at emergencymedicalminute.com.